Yes, thank you very much to everyone. And again, I really appreciate the opportunity to come out here. It's been a great meeting. I also want to congratulate the previous two speakers for some very interesting interventions. I think that's really the key to everything, I think, in our world, certainly the U.S., and so I'm really impressed in what they've been doing. I think we're going to take a little bit of a detour, not talk so much about the innovations of the valve, but how we, as echocardiographers and interventional echocardiographers, can help to support this process too, and certainly this is a very important and growing role in the United States. One disclosure and a little bit of a, sorry, a kind of a little talk on my part. I was basically a co-editor of a book on transesophageal echo for congenital heart disease, which came out in 2014, and I'll be using some sections of that in my talk. We were coming up with the second edition, and in fact, we're actually coming out with a position document in the Journal of American Society of Echo, which I'll be a senior author on that, and we'll be discussing a little bit of that too. Interventional echo, I think, is something that really has come up to the fore as its own separate field, particularly in the adults, but also probably a little bit more in pediatrics. I think we're lagging a little bit in pediatrics because of that, due to that, the fact that we're not really quite there yet as the adults are. But I think that there is tremendous innovation that's occurring in both areas, both in the adult and pediatric world, in terms of device closure of cardiac defects, in terms of valve repair and replacements, and also other innovative techniques. And again, I have to put a plug out to the interventionalists. I'm constantly amazed at the creativity that you guys have, the things that you can do, the things that you can think up. Dr. Ng is just very creative, and it's really fun to watch him, and it's also nice to be able to support him when we use our children's just working with him in the interventional lab. We know that fluoroscopy and angiography, as important as they are and as traditional as they are, continue to be the main methods of imaging, but it's clear that they have their limitations in terms of radiation exposure, which we are very aware about in the United States, as well as the inability to visualize atrium ventricular septae, valves, and other intracardiac structures. And hence, other imaging modalities are necessary to support the newer innovations, which I think you've already been able to see. So echo really has come to the fore in that way because of the fact that it has so many good advantages: real-time visualization of procedures while they're being able to be performed, ability to visualize precisely, and I mean really precisely, the intracardiac structures, not readily visible by fluoro and angio, portability and rapidity of use. We can use one machine and move it back and forth in the lab if we need to, and then, of course, lack of ionizing radiation. Several types of echo modalities have been utilized, including transthoracic echo, and in fact, I know that Hugh over in Hanoi likes to use transthoracic echo, transesophageal echo, which is my field and which I think is a much more useful modality, intracardiac echo, which I know we refer to too, but I think this requires the interventionalist to be fairly good in operating the catheter. It's a single-use catheter which becomes prohibitively expensive in the United States. Each one of those catheters is about $2,000 to $3,000, and we can't use it more than once or maybe twice if you're lucky. Maybe in other countries it's different. And it has single plane imaging, which I think is a little bit of a problem. You can actually rotate it around, but it's a little bit more difficult. And in addition, they do have 3D and 4D available. You can imagine those probes are super expensive. And I've seen them, and they're not quite that good in terms of their 3D imaging yet. There's also epicardial echo, which is being used for hybrid procedures, but certainly not on as a regular basis. You certainly couldn't use it in the interventional lab for the standard interventions. And then there is this new form of interventional cardiac MRI, which I'm not going to get into right now, which I do not think is quite ready for a lot of these devices, mainly because none of these devices is MRI friendly. Of all the echocardiographic modalities, TEE has emerged as the preferred imaging procedure due to a number of things I just talked about, but even more, the superior spatial and temporal resolution, the avoidance of the sterile field, which I think the interventionists find is very, very useful. They don't really have to be going back and forth. They have a separate operator. And also there's availability of excellent 3D and 4D imaging, which you already saw a little bit about in older patients. Again, rapid and real-time information, including 3D and 4D, and the cost compared to intracardiac echo, which I think is pretty much comparable, and we can also reuse our probe. In some hospitals, and I know certainly I'm reviewing a paper that they've done in China, where they've used basically TEE as their sole intervention modality for imaging when they're doing interventions, particularly for ASD device closures. So I think it's come a long way, and this is a list by no means inclusive of a number of different interventions in which TEE can provide support, and probably is the primary modality in which it provides support. I didn't include pulmonary over here. We don't use it as much for the Melody valves in the United States, but certainly I saw that they were using it here with that Korean device. And that pulse device, it looks like it would be good, including things such as pulmonary vein ablation, left atrial appendage ablation, which is really much more for the adults, and other more unusual interventions too. What is important when we are looking at interventional echo using TEE is that you have to have a real important familiarity with specific pathology, particularly the 3D anatomy, and the type of proposed intervention. So for interventional echocardiographers, we have to have a slightly different mindset than just doing transthoracic echo. You've got to think a lot more like an interventionalist. You also have to have a strong understanding of all the 2D TE views with from the four principal esophageal and gastric windows and what works best for the underlying pathology. And you have to be able to conceptualize and understand it both in the 2D and 3D forms. And you have to be able to change and obtain the TE views as quickly and rapidly as you can because of the fact that this information is changing constantly in the interventional setting. So this is just an example of some of the maneuvers that we always teach to our fellows and the different windows in which we use TE, upper esophageal, mid-esophageal, transgastric, and deep transgastric. These are the ones that have been published in the ASC from a document 2013 for adults, and the ones we also will use in our upcoming document for pediatrics. And these are some views that I took from my original book, but unfortunately I can't publish the ones that we're actually going to use for the JACE article, but there are 28 views that we use from the mid-esophageal, transgastric, deep transgastric, and upper esophageal views that we are going to use, that we'll use not only to communicate and to teach, but to actually obtain all the images. And you can get a lot of images by TE, but you do have to work at it. You'll notice that we inverted our images here. That's because we like to do in the anatom position for the deep transgastric. Because we're pediatrics, we want to do things a little bit differently. The interventional echocardiographer should consider himself an integral part of the procedure. You're not just a picture taker. You're not just there and then you can read and then come back and do the imaging. You actually have to be an integral part of the whole process, which is really critical success, and the imager is a lot of times involved in important decisions. Information, again, has to be obtained rapidly and efficiently. See, there's little time for post-processing for in-depth review. You notice some of those 3D pictures I took yesterday, I showed you from transthoracic. You don't have all day to do those. You only have a matter of minutes if you're lucky. So you really have to get the information as fast as you can, and you always have to be thinking along with the interventionalists about what you need to do. And ongoing communication is essential. There have been a number of publications that have talked about this, and I can attest that this is really true. It's important we're all speaking the same language over here. It's really important to describe the findings, to guide the procedure, and sometimes you need to make sure you're using the same vocabulary that the interventionalist understands what I'm talking about and why I understand what they're talking about too. A lot of times we have to be watching the fluoro as well and seeing what they're doing, even though we're looking at the echo screen. And again, prompt communication, interactive discussion are often necessary for an optimal intervention, particularly when things go wrong. This is from a document that just came out, a beautiful document from actually from the people at Cedars, talking about mitral valve interventions in echocardiography and the use of that. But I thought that was nice because what they're trying to do is standardize how you look at a mitral valve when you're doing some type of intervention on it there. And so they talk about using it as faces of a clock. I don't think we've gotten that standardized yet with interventional echo, but I think we'll probably have to get there at some point with certain types of interventions, just so that we all speak the same language. Also, interventional echo is more than just the procedure itself. It's pre-procedural evaluations, establishing optimal views. It's looking at physiology, and it's using sometimes multimodality imaging. I noticed that in the previous talk, you guys used a little bit of some 3D CT, it looked like there, and I think that's certainly being used in the adults a lot more, and really being able to plan things out. So multimodality imaging is important. Procedural guidance, including 2D, 3D, and 4D TE, is something that is done during the procedure itself. This is where TE really plays the role, more so than, again, transthoracic or ICE. So pre-procedure, procedure itself, and then post-procedure, looking at it afterwards too. Our job doesn't end when we've finished with the procedure. We actually have to follow these patients afterwards, look at things, we know what we've seen, and so we have to play a role in that as well. So an interventional echocardiographer is more than just a picture taker. You're really playing an important part. The fundamental TE modality that we're using in pediatrics right now is 2D imaging as well as color flow and spectral Doppler. And the reason why is we don't have the ability right now of a 3D pediatric TE probe. So while while this is still the fundamental approach that we use, 3D and 4D imaging, when you can get it, is very useful because it improves the understanding of the pathology. People are using an increasing number of interventions, and certainly the adults, they're using 3D TE a lot to try do with a lot of their interventions. Unlike 3D TE echo, like I said, that we're doing in transthoracic, you really don't have a lot of time, though, to crop and rotate images. So and the frame rates aren't as good. You don't have as much color flow Doppler, and you can't do spectral Doppler. So therefore, 3D and 4D is more of an imaging kind of guiding procedure. I'm going to show you a really nice example of that in just a moment of how we can use 3D. But usually the study that we're using 3D in also has to have some 2D imaging as well, or multi-plane imaging to be able to really optimize things. The frame rates are slower, so that's harder too, and you can't really do the segment, you really can't do the thing where you try and get the high frame rates and the multi-volume data sets that you try and do when you're doing just a transthoracic 3D imaging. This is an example over here of a patient who actually had pulmonary arterial intact septum, and Frank remembers this. This patient had protein losing neuropathy, had a calcified extracardiac fontan, so therefore, when we were talking about doing a fenestration, we couldn't really pierce through this over here. That wasn't going to be easy. It's Gore-Tex anyway. So this patient, we talked about trying to do a fenestration, but the fenestration would be like this. We're in a sagittal view right here, and this is going to actually be the right pulmonary artery, and we're going to see trying to go into the atrium right over here. And so Frank's question to us was, could you actually do this? Is there space? Would you actually go into the outside space of the pericardium? And we looked at it and we said, no, that's not the case. Actually, the pulmonary artery sits right on top of the atrium over here, and there is a possibility that you can actually be able to get through. And so this is what happens. So this is using actually real-time 3D, where he's actually putting a needle through and actually being able to poke through. And then the next one shows as he gotten the wire through, and then we'll see the balloon coming through. This is all real-time 3D. And then afterwards, he'll put the stent on. It looks kind of funny when you put the stent on top of the balloon here. Right here, here's the balloon, here's a stent on it. And then he goes ahead and expands the stent. And this is all being done with real-time 3D. Afterwards, we're using a biplane mode here, an X-plane as we call it. And you can see that there's now a nice right to left shunt that's occurring. This is then you looking at that stent as it's been expanded, has a kind of an hourglass type of shape to it. Here's the opening in the middle, and we can just rotate this data set so we can see it from different ends. This is the aortic valve, and then we can see it on FOSS. Here's the opening in the middle too. So a really nice example of how we can use 2D and 3D imaging to really look at things. I know Frank really told me that he really appreciated having that imaging there because you can see how close we were to the aortic root there. And 3D imaging and 2D and 3D were very important in keeping away from that aortic root, which you couldn't really see as well by standard imaging. Transcatheter valve implantation in congenital heart disease, you've heard a lot about this already. I'm not going to talk much about the pulmonary valve, like I said, because we really haven't done it as much, but I will talk a little bit about some of the other things that are important, including the MELODY and SAPIEN, which I think not only are being used in the pulmonary position, but in other positions as well, like hybrid therapy for mitral and tricuspid positions, both in the MELODY, using the MELODY and SAPIEN, native valve percutaneous repair we talked about, and newer generation implantable valves. And I think certainly for pediatrics, this is a very interesting area, the MELODY and the SAPIEN. I'll show you one interesting example of a patient who had a MELODY valve in the mitral position. This was done as a hybrid procedure. So a 13-month-old patient who had status post AV canal repair, significant mitral regurgitation, underwent a MELODY valve placement in the mitral position in 3 months, but 10 months later developed significant mitral stenosis and was brought back to the cath lab for mitral valve dilation. To summarize, this was an AV canal patient that because of the small size, at 3 months of age, we felt we could not put a mechanical valve in, so the decision was made to put a MELODY valve in the mitral position, which we are doing now as a hybrid position. This was done in the OR. This is the MELODY valve. Dr. Inges showed you about that, and a few changes. Anterior edges are flared outwards like this. These are images I borrowed from them, and it's placed, basically they put a skirt around that they could put in the mitral valve annulus. Forgive me, I'm not an interventionist in that sense, so I can't explain all the technical details as easily. But here it's actually being inserted by the surgeon with Dr. Ng present there. So they're using the skirt here and putting it in place, and then they use a balloon. Dr. Ng uses a balloon filled with fluid to actually open up the valve. I think it's actually contrast that he could actually see also. And this is afterwards with TE. This is at the time of the initial implantation of the MELODY valve here. And you can see that it's actually working quite well. This is a mid-esophageal four-chamber. This is a mid-esophageal long axis. This is a deep transthoracic view, and no significant LV alpha tract obstruction. Okay, fast forward to the present. Here we are with this patient now 10 months later, and you can see has fairly significant, there's a melody valve not leaking a whole lot, but with this fairly significant gradient, with a mean gradient of 15 millimeters of mercury. And you can kind of see it. This is the mid-esophageal long axis. And so it has gotten a little bit more narrow throughout, and there's also maybe a little bit of turbulence across the alveolar tract, and we were, of course, concerned about that. So, and you can see a gradient about 2 meters per second. So we're doing this all the time. Now this, unfortunately, we couldn't do 3D. Here we are. Now he's going to decide to go ahead and dilate. This is from mid-esophageal 4-chamber. He's got the catheter in place there. And then he'll put the balloon in and try and dilate up the valve. And here we'll start to see in just a moment. Here's a 14 millimeter balloon as he dilates it up. Here we go. Pretty significant dilation right over there. We were actually doing this in front of a live audience, too, which is pretty interesting. It was being broadcast. And then afterwards, this patient became very bradycardic and hypotensive. And you notice over here, actually, heart rate is not as fast as you think, because this is recycling through a loop. But look at the turbulence right over here, the distal end. It's pretty narrow over here. And what you'll see also is that they have, we have a little bit of a gradient, but what you'll see is that there's a little bit of alveolar tract narrowing, too. We were wondering about could that be the reason why this kid was bradycardic. But it became obvious that the mean gradient across the mitral valve was pretty significant. It was about 9 mean gradient, but look at how the RV was dilated. So it became obvious that the LA pressure had gone up, probably because of mitral stenosis, and it caused some significant pulmonary hypertension and bradycardia and hypotension. So Frank said to me, what do you think? Should we dilate this valve? I said, yeah, we better do that. So he did. I don't unfortunately have an echo of him when he dilated it, but this is afterwards, and you can see right after he dilated the distal end of that stent of the melody valve, it opened up significantly, and the patient's heart rate came back, and so did the blood pressure. And you can see now there's no more gradient across that area, too. So he did a really nice job with that, and fortunately, you can see the mean gradient came down to 4 millimeters of mercury. So it really improved quite a bit. And the other important thing is you can see that the RV function is much better than it was before. So I think that the example of this is how important it was for the ongoing dialogue. This was an interventional echo procedure, but when things got tough, it was important for us to be able to communicate together and discuss the findings. And I think the echo was really useful in seeing what was going on with the patient and being able to react quickly, because believe me, we were only a few seconds away from starting to do CPR on this patient. So other newer interventions requiring TE guidance include things such as transcatheter mitral procedures, mitral valve repair, mitral valve replacement, transcatheter tricuspid valve repair. I bring these up because these are not really something we do in pediatrics, but hopefully we'll see. But I am just amazed at the innovation that's going on and how TE has to come in to support this too. TAVR, of course, we know about, and left atrial appendage occlusion. Just a few words and then I'll finish up here. That the mitral, for example, I think right now mitral valve interventions in adults are just incredible. You see what they're doing now. Balloon valvuloplasties, leak closures, edge-to-edge repairs, mitral valve annuloplasty, cord implantation, and of course transcatheter mitral valve replacement. And 2D and 3D TE have become essential for the development and application of these new transcatheter mitral valve technologies. This is from a recent, well, this is a little bit older article, but talked about some of the procedures that are being done on mitral valve leaflets, chordae, and the annulus themselves. They're doing annuloplasties, as well as some of the new transcatheter mitral valves that are being developed and implanted into adults right now. And it's really incredible to see what's going on. You, of course, know about the mitral valve clip. The mitral valve clip is really basically converted to a double orifice mitral valve. This is all being done by TE, essentially. And what they do is they essentially put they do a transeptal puncture, again by TE, a lot of times by 3D TE, and essentially put a clip right through there to create a double orifice type mitral valve. This is all pretty amazing over here. And then the other thing that's really interesting, as I talked about, is pre-procedure planning, where here this is from a more recent article where they're actually using CT and some customized software to get an idea about how you're going to put the valve in place and whether there's going to be any alveolar tract obstruction at all, sort of like this. And so to assist planning, this was actually 3D printing, where they found a lot of calcification over here, where they're thinking of putting the SAPIEN valve, and also they were concerned about possible obstruction to the alveolar tract. So these are all really important things that are coming out now, and I think probably we'll see this a little bit more with pediatrics too. I'm just going to move on a little bit more here. This is the implantable SAPIEN valve. I'll just show this real quickly. This I actually took from the article that just came out in 2018 about how they noted the fact that you could expand the SAPIEN valve. This is a valve-in-valve. This patient had to buy a prosthetic valve in place. So they're expanding it right here. Well, but the fact is that they said we don't know exactly where we are, and this is why we needed to have 3D TEE. And so when you use the 3D TEE, you could see that, sorry, I'm just waiting for this to be finished here. Here's the valve afterwards here. You can see how beautifully you see it and how you can see how the leaflets. So the 3D TEE played a really important role in being able to look at that. So finishing up, I just want to say one thing about radiation exposure. Again, it's something we have to be aware of as TE people. I know that we have to wear lead and everything too, but this was a really nice article that came out earlier this year that talked about how the TE operators had just as much, if not more, radiation than the operator, and much more than the second operator, and certainly much more than the anesthesiologist who sits behind a lead screen. But when you use a shield, you can actually reduce the amount of radiation that you have, and so we're actually getting that for our own lab now, these shields that allow us to, because we're right next to the patient. And I think this is important to be aware of this too, especially if you're going to start doing a lot of these. So in conclusion, the field of interventional cardiology continues to innovate and grow. So will the need to be able to evaluate the interventional techniques using high-resolution imaging. 2D, 3D, and 4D TE, I think, are going to be ideally suited for this. And hopefully, with the advent of a pediatric 3D TE Pro, will be helpful in pediatrics as well. Important for intervention imagers to really adopt the mindset of an interventional echocardiographer. That starts at the pre-procedure stage, continues through the procedure, and to the post-procedure imaging. And in closing, I just want to show one thing. This is one of my favorite post-Renaissance artists, Caravaggio, who was a scoundrel but tremendous. But I loved the way that he did shading and lighting. He influenced a generation of artists. And I really think that when we do 3D echo, actually, we try to get this same type of rendering too. So I've always been inspired by Caravaggio. Thank you very much.